Very much for this introduction. So I will defend this position. Should we have a CVP? My answer is no. Clearly no. But before starting my arguments, I want to know among of you how many people use CVP regularly. Okay, not too bad, not too bad. Of course, I will talk about patients with shock or patients with severe ARDS, not patients just with nothing. I have no conflicts of interest for this presentation, of course. So, first, what is CVP? CVP is the pressure in the superior vena cava, and it reflects the right atrial pressure. It should reflect the right ventricular filling pressure. This is a very simple cartoon with CVP, which reflects the right atrial pressure. And therefore, it should be a marker of the right ventricular filling pressure. But in addition, CVP reflects the back pressure for venous return. You know that the upstream pressure is reflected by the mean systemic pressure, which is the upstream pressure. And CVP is the back pressure. In addition, CVP reflects the back pressure for organ perfusion for the majority of organs. I talk about the liver, the kidney, the brain, for example. Like this. This is the upstream pressure for organ perfusion, MAP, mean arterial pressure, and CVP reflects in the majority of organs the back pressure for organ perfusion. Okay, how to use CVP and how do I use CVP? Of course, not for predicting fluid responsiveness. This could be a big mistake. And years ago, now more than 20 years ago, in this study with Frank Misha and others in my unit, we showed that CVP was not a good predictor of fluid responsiveness when you look at the area under the ROC curve. And this was demonstrated many years ago, 20 years ago in this study. And this was confirmed in many other studies, and this review article published in 2002, we said that dynamic parameters should be used preferentially to static parameters like CVP to predict fluid responsiveness. And this was confirmed by many other studies. This is a meta-analysis by Paul Merrick and others showing that CVP cannot predict at all fluid responsiveness. It's just like tossing a coin. And now, the international societies recommend to use dynamic parameters instead of static parameters like CVP. There is no doubt about this. So, I use CVP first for suspecting RV dysfunction, right ventricular dysfunction, just at a glance, and for monitoring its response to treatment. If you use CVP as a marker of the right ventricular filling pressure, it could be very interesting to guide treatment, for example, during shock and ARDS, for example. This is an expert opinion paper on management of hemodynamics in ARDS patients. And in this paper, we said that a central venous catheter is mandatory in ARDS patients, mandatory. And it is said that it is mandatory because it allows measurements of central venous pressure, but also SCVO2, and to monitor the response of RV function to treatment. And the first author of this paper was Antoine Villard-Baron, your friend, your very good friend, and you share many bottles of wine together in many restaurants. This is only one of the pictures I have. I have so many others. And when I look to PubMed and I put the names Villard-Baron and Mayo, it is your name, Mayo, I found 26 results. And this guy, who is on the first row here, recommended to insert a central venous catheter to measure CVP, to monitor the response of the right ventricular function to treatment in ARDS. So this is I respect this. I respect this guy. Of course, if you measure CVP as a marker of the right ventricular filling pressure, you should take into account the transmural CVP, which can be overestimated by the measured CVP during PEEP or PEEP-I. Another way to use CVP is for estimating the back pressure for organ perfusion. For example, if you have a high CVP, this high CVP has two consequences. The first consequence is to reduce the organ perfusion pressure, which is the difference between AMAP and CVP. And if I look at this very simple graphical representation of the autoregulation of organ blood flow with organ blood flow on the y-axis, you can put the renal blood flow if you want, and AMAP. In fact, the relationship is not AMAP alone, but AMAP minus CVP. This is the organ perfusion pressure. And sometimes it counts a lot. And Daniel De Backer and others in this paper said the organ perfusion pressure also depends on the downstream pressure, which is very important. That is to say, the central venous pressure. And at least to select the optimal AMAP, CVP should be considered together with comorbidities. But also, if you have an increased CVP at the level of the venules, you have a risk of interstitial organ edema, which can also alter the organ function. And both effects, reduction of organ perfusion pressure and increased in the interstitial organ edema, can result in organ dysfunction. And this is well illustrated by some studies. This is a study by Mathieu Laurent with mean CVP on the x-axis and the risk of new or persistent acute kidney injury. And the higher the CVP, the higher was this risk. Another study from the group of Rinaldo Bellomo showing that in patients with septic shock, higher CVP values were independently associated with worsening acute kidney injury, whereas other hemodynamic indices were not. And also this study by Marlies Osterman showing that the mean perfusion pressure, the difference between MAP and CVP, but not MAP alone, was an independent factor associated with acute kidney injury progression. And they found a value of MPP of 60 meters of mercury. In other words, if you have a MAP of 65 and a CVP of 15, it's not enough. You should either increase MAP or better, try to decrease CVP. So it is very important to take into account CVP. And this is a meta-analysis. We have always meta-analysis for everything. And this meta-analysis showed that elevated CVP is associated with increased mortality, increased risk of acute kidney injury. So you should agree with me that central venous pressure is a pivotal hemodynamic variable. This provides important information on the right ventricular function and on the mean organ perfusion pressure. And Daniel De Backer and others said that CVP should be understood as a complex but informative variable, and routine measurements in patients with shock should be promoted. Having said that, can we estimate CVP non-invasively? And of course, Paul, you should be very happy to do this. Look at your smile. But unfortunately, it does not work. It does not work. This is one of the analyses of the literature recently showing that if you take the IVC diameter, the maximal value during the entire respiratory cycle or during end expiration or end inspiration, whatever, in patients with spontaneous breathing, you have very weak correlations between the diameter and CVP, very weak correlations. But in patients with mechanical ventilation, No correlation at all. No correlation at all. Either with the diameter or with the IVC collapsibility in patients who receive mechanical ventilation, patients who are talking about just today. And now, the International Society of Echocardiography, the American Society, said the IVC, inferior vena cava, is commonly dilated and may not collapse in patients on ventilators. So it should not be routinely used in such cases to estimate the right atrial pressure. This is why now you do not smile anymore, Paul. I'm sorry. So my conclusion is, should we use CVP today? Yes, but not for predicting fluid responsiveness, of course, but for assessing RV dysfunction and its response to therapies, for assessing the back pressure for organ perfusion. And why? Why deprive yourself of this important variable, especially when a central venous catheter is already in place, and it is so simple to connect this central venous catheter to a pressure sensor and to have this information. Thank you very much.
Thank you for this. I would like to invite Professor Paul Mayo to the stage now. He's a professor in New York at Northwell System. He's already getting ready for this debate, so I'll leave the floor to him.
We will speak about the sky above and the mud below. Dr. Teboul lives in the sky at the not the Kremlin hospital. He lives there at the acme of the physiologic world. Every measurement he makes is accurate of CVP. We're going to review how he does them. Whereas I live in the mud where all of you live, in busy ICUs. And let's talk about some of the technical challenges, because when Dr. Teboul talks about the CVP, what is he measuring? And is that measurement accurate? And if it's not accurate, it has very limited utility. What should be measured? The classic approach, and I came from a program where I was a slave to the tradition of Cournand and Richards, who got the Nobel Prize for this work. I was trained that you had to identify the end expiratory, end diastolic pressure as your central venous pressure. And this was done by printing out a tracing, by sitting down with the tracing, by identifying the relevant measurement point, including end exhalation, and then the report was required to determine the RAP, end expiratory, mean, AV, but if you could find a Z point, that would suffice as well. How many of you look for Z points every morning on your tracings? It takes time. So already I have a problem. Who is willing to do this in the mud below? In the sky above, yes. I'm not so sure. And here we have some examples of some typical right atrial pressure tracings. The one up on the right, that's the easy one. Do I have a pointer here? Probably, yeah. Nice and flat. Oh, yeah. Oh, we're going to have to sit down and we're going to have to look, identify the A, the mean AV, et cetera, 15, all right, that's good. We're going to talk about zeroing in a moment. Yeah, these ones get a little more complicated, rest phasic variation. And here's a really good one, all right? Where are you going to measure this? And as soon as you have dysrhythmias, you really have to know what you're doing. This cannot be done in any automated way, all right? And therefore, in the go-go years, when I grew up, in the go-go years of PAC CVP, trace interpretation was mandatory. I literally was required to do it thousands of times during training. And this may be done by Teboul's team, but my own observation, and I see a lot of unit teams at work, nobody does it because they're in the mud. And they rely on the monitor screen output. Really, is that machine algorithm, can it deal with these measurements? Well, that's been examined. A long time ago, they say, no, you better look at the graphic recording. Now, I agree, there's some more recent literature saying that it's not too bad, the monitor. I doubt that literature. I want to see the types of patients they were doing, okay? I believe the Ahrens paper that you have to do this manually, that a machine cannot do it for you. There are some other dirty little technical problems that have not been mentioned by Dr. Teboul. He talks about the concept of central venous pressure, but zeroing is a key element to the accuracy of the pressure measurement. And one of the big problems is that central venous pressures are not that high. So your zeroing has to be extremely accurate. If it's off by a couple of centimeters, then that central venous pressure is off by a couple of centimeters. And if it's off by more than that, then there's a real problem, okay? And small errors are not relevant to arterial pressure. That's very high, right? But for central venous pressure, so how do clinicians do when they zero the systems? And I'm not even talking about nursing staff who's in a hurry, and they don't do very well. Here's a nice example of that. Even with laser zeroing, all right? And the reason for that is we're supposed to do it in supine position without the patient angled at all, no pillows or anything. That'd be totally flat, right? And then in some way, if you're a sternal angle person, you're going to find the fifth rib at the mid-thoracic level, which is maybe easy to do if you have time to do that in a skinny person, but in a large person, forget that idea. It's a fantasy. You can't feel the ribs. All right, so then we could do another, 5 centimeters of the sternal angle, regardless of patient angle. Whoa, so my wife weighs 45 kilograms. She's a very small woman, but a brilliant physician. I look at my big partner, who's very athletic. He's 6'8". There's no way that his right atrium is exactly 5 centimeters below the sternal notch. Then people are obese, their chest walls become... This is a silly, silly idea that you can find the phlebostatic axis for zeroing in a lot of our patients. And Dr. Teboul made a vicious attack upon echocardiography, a vicious, brutal attack. I would refer to him a novel method in the Journal of the Society of Echocardiography. It's an idea that I never thought of, even though I've done 10,000 echoes. This group measured the distance between the center of the right atrium and the skin surface in vertical distance to define the exact phlebostatic axis. Great idea. And then they adjusted the vascular probe to find the top of the jugular venous pressure thing, and they got quite a good estimate of CVP. So I wouldn't kill yet echo for this application. It's a very interesting article. I wish I'd thought of it myself. So then there's this odd thing, in addition to the zeroing issue, in addition to the disutility of monitor-derived values, in addition to the lack of time to perform an actual accurate measurement of quote-unquote preload of the right ventricle, we're going to get on that in a moment, that very interesting article where this group had PA catheters in their patients, and then they had another type of catheter in the right atrium, something like a hemodialysis catheter, maybe a central venous catheter, and they compared the values of the right atrial pressure using two different catheters that were in the right atrium, and they had a big variation. So something we don't remember is we don't know where the catheter tip is in the right atrium. We may know with echo where the actual true phlebostatic point is, but where's the catheter tip? Is it directed upwards or downwards? And there's a perfect example where you have quite a broad spread in the same patient with two separate measurement sites. That's a little worrisome. And you look in plus or minus 3 millimeters, which is like 4 centimeters of water. I'm starting to get very worried about the accuracy of this measurement. So let's assume that the clinician has actually zeroed the system properly, that they think the catheter is where the measurement, the 0 point was, that they've decided we're actually going to print it out. And Dr. Iberti, in an old article using PO, he found that MDs and nursing staff at the time of true universal application of these catheters in the 90s, only about 60% of clinicians actually could interpret the tracings. That's a little worrisome, especially now when people really aren't practiced doing it, okay? So, I thank Dr. Teboul for reminding us that for prediction of volume responsiveness, it has no utility. I'm glad we agree on that. But there are conceptual problems to the idea that it reflects in any way the, quote, preload of the RV, because as I understand it, preload reflects the volume of the ventricle. And does the pressure reflect directly the volume of that ventricle? And the ventricle may have very uncertain compliance. The pericardium may contribute, and the thoracic pressure may contribute to the effect of pressure on that chamber. And therefore, I would propose that central venous pressure has uncertain relationship to preload, whereas echo has every relationship to preload, because that detects volume. It certainly doesn't surprise us, therefore, that CVP doesn't predict volume responsiveness very well. Let's just say it doesn't. It also encourages sort of simplistic thinking because it ignores the other friend, which is the LV. All right, that's a whole nother discussion. So there are some Guytonian issues here, which Dr. Teboul has referred to. He reminds us that venous return, which equals cardiac output, is the mean systemic filling pressure minus the RAP over the resistance to inflow. And this suggests in an odd way that it's advantageous to have a low RAP. Therefore, I'm happy my right atrial pressure is low. It's probably around 2. I've got a lot of venous return, right? But the patient in shock who has a very low right atrial pressure, well, maybe they're not like me, right? And we should only consider the possibility of volume resuscitation, get out the echo machine to do the real study, because we keep in mind excessive volume resuscitation is detrimental. It may not last that long. As we know, it distributes into the interstitium quite quickly. And of course, we thank Dr. Teboul and his main co-conspirator at the Kremlin, Dr. Monet, for the reminder that with relative hypovolemia, with sepsis, norepi may be the best lead-in with a little bit of volume to redistribute volume to the compliance compartment. We agree that one very useful utility of CVP is it's a marker for venous congestion. But why don't we ask our friends in Montreal about the VEXUS score, or that concept, and as long as you're doing the echo, which all patients require, you might as well make more formal measurement of the true culprit by measuring portal venous inflow, hepatic venous inflow, if you can get it, renal velocity profiles. And this, of course, is an advertisement for the advanced echo course next year, same time, same place as the weekend. Failure points for use of CVP. Has to be read from the graphical tracing, in my opinion. There's inappropriate reliance on the monitor value, garbage in, garbage out. There's inaccurate zeroing. There are major problems with determination of phlebostatic axis, knowing the catheter tip position, and then the problem of repositioning the patient after the system has been re-zeroed. You see it at bedside, there's neglect in making these zeroing measurements. This is compounded by a modern generational issue of lack of training and determination of RIP. I insist that my fellows be able to do the classic interpretation of the tracings. They resent it, they think it's an old person's foolishness, but it's important that they know that for the physiology of cardiovascular function. But at the bedside, and then small accuracies in measurement may have major effect on your conclusion. I agree that interpretation and knowledge of the tracings are really important conceptually in training, but is it a useful bedside tool? And then, what's community standard? I can tell you that in New York City has probably about 1,000 ICU beds. I am personally familiar with the function of at least 500 of these MICU beds because I know their directors, I know their juniors. I trained most of the directors. And when I ask, they simply laugh. What? Central venous pressure? What are you talking about? Literally, they all do a lot of echo. Now, some of the surgical intensive care unit teams still seem to be devoted to the monitor tracings. So yes, all of New York City MICU could be wrong. But I hope it's unlikely. Yes, on time. I went a little further than Dr. Teboul, but we have some time for discussion.
I think we just have 30 seconds for discussion.
No, really?
Right. But we can try with one question, maybe.
Okay. I have a question. Who, after hearing the two sides of the debate, will... Yeah, all right. So, raise your hand if you'll be using CVP tracing for clinical utility when you go back to work next week. All right, those who will not.
You lost.
All right, Jean-Louis, will you repost here? Yes.
Could I just ask one question? I think so the majority would use CVP when you take into account a lot of pitfalls that you pointed out very carefully. But how would you use it? Do you have a value that you would use or a trend or what would you do?
Just I want to say that Paul emphasized on the source of error of measurements, of course, but it is our job to know how to do. It is our job. We are intensivists. We have to handle patients with 30–40% chance to die. So we should know how to do. If you don't know, you can learn. Do you think that it is easier to perform echocardiography? No, probably not. So this is the point. So if you know your job, if you want to pilot an airplane, you should learn. Of course, you should be trained. You should be educated. It's the same for CVP measurements. And once you know how to do, Believe me, it is a wonderful parameter. And when the limits you talk about, the zero, etc., I agree. But if you look at the change in CVP, the problem of the zero disappears.
But I think we all agree that they are complementary examinations, the echo and the...
Yes, it's called echocardiography. And Dr. Teboul, I sort of get the impression that he would propose we use echo only for estimates of CVP, for VEXIS scoring, but echo gives you a bit more information about cardiovascular function than estimates of central venous pressure or venous congestion, right? It has just a few more utilities. Yeah.